The story goes, before I came to the northern part of Europe, I did a little bit of research, as it may. And one of the things that we were talking about in the car on the right up here is that I found out that the average veterinarian in Northern Europe is more likely to do a profile than a CBC when given the option. So you could do one or the other. The thinking being that a profile is more likely to help you figure out what your patient has. And you know, because I'm a clinician, I do profiles on and off, but I usually derive as much or likely more information from a CBC than I do from a profile. So a couple of disclaimers. I am not a pathologist or a clinical pathologist. I'm a clinician like you guys. So I used to work in a large veterinary teaching hospital for 30 years in Ohio, and now I'm working in a clinic in Pennsylvania starting in a couple of weeks. But I actually do like hematology. So I'm boarded in internal medicine and I am boarded in oncology, but I do like hematology. I do some consulting for IDEXX, and that's what I'm here today. So this is called full disclosure, all right? So you look at CBCs, and I'm going to talk about dot plots in a minute, and Dennis De Nicola, that some of you know, who is the head of education for IDEXX, actually gave me a couple of the dot plots that I will show you today. The dot plots are, to me, an integral part of a CBC, and I'll tell you how I look at them here in a few minutes. I know that you guys do emergency service, and when you do emergency medicine, a CBC quite frequently gives you a lot of information. So if I have a dog that comes in with collapsing episodes, for example, yes, I will do a glucose to make sure they are not hypoglycemic, but I will do a CBC to make sure they are not septic, they are not anemic, they are not bleeding in the brain, they don't have a lot of other issues that I could uncover from the CBC. In the typical clinical setting, I will do a CBC to confirm a presumptive diagnosis. And we were talking with two of the groups yesterday, and every single one of us in this room uses the brain differently. When we look at a patient, we all approach the patient slightly different to radically different. I may go around through the right, and you may go around through the left, but usually we get to the same destination by doing similar things, perhaps in different sequence, perhaps in different order. But I like to have what I call a working diagnosis. So when I look at a patient, I like to say, this dog has immune-mediated thrombocytopenia until proven otherwise. And I want to have an alternative diagnosis, or a plan B. So if I have a cocker with petechia and ecchymosis and everything else looks good, I will go, that dog has ITP, or immune-mediated thrombocytopenia, until proven otherwise. But if she does not have ITP, what could she have? Well, maybe a tick-borne disease or a drug-associated thrombocytopenia or something like that. And the reason I like to do that is because, to me, a very lengthy list of differential diagnoses does not help me. And we were saying yesterday, you have all gone to congresses or lectures, and you have an internist talking about respiratory distress, and they show you 4 PowerPoint slides with 10 lines each of differential diagnosis for respiratory distress. Tell me how that is going to help you. It's not going to help you, because what you need to do is you need to be able to sort them out, triage them, and say, based on the signalment, the history, the physical exam, and the additional diagnostics, is either this one or that one. Because if you think about it, you almost never go past the second in your list. If you did a really good job ranking them, you almost never go past the second in your list. So that's the way my brain works, all right? And not every brain is wired the same. There are lots of books about how the brains of internists and surgeons and pathologists and imaging people are wired, and they're very different. Wires of different colors, all right? So we in the States do a lot of wellness, and the reason for that is a lot of veterinary pharmaceutical companies and companies that make equipment like IDEXX years ago started making a big pitch for preventive health care. You know, in the United States, it's very common that you are a person of any age, I would say after you're 20 or 22, and you usually go to your doctor once a year for your annual checkup. You know, and your annual checkup is usually a physical, plus or minus a CBC and a profile or something else. And because humans are used to doing that, they go, it's perfectly logical to do that with our dogs and cats. So we see a lot of wellness visits in the States where the dogs come in or cats come in once a year just for a physical and a CBC and a profile, a T4 or something along those lines. And when we talk about subclinical changes is when we basically have no idea what's going on with a patient and we kind of go fishing. You know, we do a CBC and a profile hoping that they will help us figure out in which direction we're going. Monitoring, you know, Nana does a lot of chemotherapy, so we actually do a lot of sequential CBCs following up on these dogs and cats that are receiving chemo. You will do sequential glucoses in diabetic animals and stuff. I'm not going to bore you with any of that. Before I go into this, let me ask you this. So when you went to veterinary school and they taught you to read CBCs, all right? So you went to vet school and you had a hematology class or a clinical pathology class. How did they teach you to read the CBCs? They probably taught you to look at the numbers, correct? If the numbers are high, they mean one thing. If the numbers are low, they mean a different thing. Yes? Is that the more likely scenario? Now, when you went to vet school, some of you may have learned about dot plots. When I went to vet school, they had just invented the microscope, so I didn't know anything about dot plots. And we learned about looking at blood smears, you know, and in Argentina, where I went to vet school, in first year, we spent a lot of time at the scope. We spent a year at the scope doing cytology and histopathology. So the bottom line is, dot plots are new, and like everything new that you are encountering, sometimes you're a little intimidated and you go, should I look at them or should I not? And then you look at them and you go, this is very pretty, but I have no idea what it means. So I'm going to fold this report so that the dot plots do not show and I don't have to worry about them anymore, all right? And I'm going to try to convince you that you should not do that. So if you look at practices, you know, you guys have a lovely practice here, beautiful place with lots of nice equipment. And in the States, about half of the practices have their own analyzers. And when you talk to veterinarians, the first thing they tell you is that they have to feel comfortable with their analyzer, whether it's chemistry or hematology, it doesn't matter, but they need to trust them, all right? And trust them means that the instrument has to, more often than not, confirm that the dog or the cat has what they think the dog or the cat has, all right? So what do you think the possibility of that happening is? Is that likely or unlikely? How many times do we miss a diagnosis in the clinic? Often, all right? So remember, we were talking about, do you guys know how often a pathologist misses a diagnosis in human medicine? 25 to 30% of the time, okay? And this is in the United States by a pathologist, human pathologist, when compared to a consensus panel of pathologists, all right? Cytology the same, in veterinary medicine is about 30, 35%, depending upon where you read. Same, you guys know what is the error rate for mammograms in the United States? 20%. That includes overreading and underreading lesions. So bottom line is, your brain tells you the instrument is going to verify that the dog has what I think he has, and the dog may have something different. So then how do we handle that? How does our brain handle that? We say, but this instrument is no good because it's telling me that the dog has a different thing. So we'll go through that in a little bit. I learned today that you are very fortunate that you have people working in your practices that specifically do hematology chemistry and look at cytologies and blood smears and whatnot, and that is not the case in the US. You know, in the US there is frequently a technician in the practice that is interested in microscopy, and they look at cytologies and blood smears and whatnot. But when you talk to veterinarians in the States and you ask them how many of them look at blood smears, nobody raises their hand. You know, blood smears are also in the I must not look at them because I don't know what I'm looking at category, all right? So it's best to stay away from them. So if you are going to use you know what I'm going to do? Let me cut this because I'm going to show you a shorter version of this, because what I did is I screwed up But don't tell anybody because they're filming me at the moment. So what I did is I started with a long version, and you don't want that because there will not be enough of those buns to keep you awake. All right. Now we're almost there. You see, it was very easy. What happens is as you get older, your brain starts to go to different places, and when you're jet lagged, it gets a little worse, and when you didn't sleep the night before, it gets just a little bit worse. So, all right, so if you look at the CBCs in your practice, and two totally different settings. So you folks do some healthy pets probably, you do pre-surgicals, pre-dentals, and potentially some health checks, but you also do emergency dogs, cancer dogs, sick dogs that are going to go to surgery because they have whatever disease. And the goal of everybody, and let me tell you the way it works in the States, the goal of everybody who sells you an instrument is that you will never have to look at a blood smear, okay? And I don't know when that is going to happen. It probably will never happen, okay? Because we still have to go to Van Leeuwenhoek's methodology to verify that what the instrument tells us is true in some of the cases, okay? So there are some cases, depending upon what type of case load you're dealing with, where you will have to look at blood smears. We were having that conversation in the car today. Some people tell you that you should look at every blood smear that comes out of an instrument. My approach is different. If I have an instrument that I trust, and we use a ProCyte, I look at the smears only if the instrument flags the cells, all right? So if the instrument tells me, I don't know what that cell is, that instrument is telling me, you better look at the smear because I don't know what that cell is, all right? So the alternative way to look at that is you will say, the instrument just flagged a cell because it's no good, okay? As you will see, these instruments are pretty darn good. I'm gonna show you some data here in a little bit. So if you're in an oncology practice, I probably look at CBC blood smears 5, 6, 7 times a day. If you're in a practice where you do pre-surgeries, pre-anesthetics, you may look at smears once or twice a day because all your values will be within the reference range. All the values will miss or lack that asterisk that is telling you you have to look at the smear. So I'm going to show you a bunch of cases to illustrate that. So if you look at benchtop instruments, this is a study from a few years ago comparing 7 different instruments with 2 of the benchtop analyzers that are used in commercial labs, and all the instruments are really good. You know, this is before the ProCyte, so they look at the laser side and they have very, very good results. And we actually published some stuff on the laser side looking at chemotherapy patients, and we looked prospectively at dogs and cats undergoing chemotherapy, and we looked at 105 dogs and 25 cats. And what we did is we compared the results of the laser side without a manual differential to, and that's what the LC stands for, to those of a cell dyne that a lot of you know is an impedance counter with manual differential. So an impedance counter is not very good at giving you differential white cell counts, and it gives you a 2 or a 3-part differential depending upon the instrument, so you actually have to look at the blood smears. All these numbers that you see there, 0.92, 91, 93, and 95, are excellent correlation. Anything over 0.89 or 0.88 is considered an excellent correlation. So these instruments work as well as the 120,000 or 150,000 euro machine that you have in your commercial lab. Same for the cat, and remember, the exception to the rule with a cat are the platelets. And we always say that the best way to count platelets in a cat will be to be able to go inside a blood vessel in a cat and count the platelets, all right? Because the minute you take them out, they don't like it, and they all kind of hug together, they go to the bottom of the tube, and now you cannot really find them very, very easily. So for cats, a direct blood smear is really, really helpful, and I always look at platelets per oil immersion field when I'm doing a blood smear in a cat, and I also use that to look for hemobartonella or mycoplasma. Remember, the mycoplasma sits outside the cell and doesn't like EDTA. So if you have a cat with mycoplasma infection, you send that sample to a reference lab and there will be no organisms on the cells by the time they reach the lab. One of the things that we all know, even if we have a great lab, even if we have a great blank-ologist, all right? If the dog tells us one thing and the ologist or the lab or whatever tells us a different one, the dog is right, okay? It's extremely unlikely that a patient will be wrong when it comes down to their own disease, but it's very, very common, as we said before, that human error will play a role in what we diagnose or what we think we are seeing. So how many of you know what a flow cytometry is? Anybody knows what flow cytometry is? So let me tell you what this is. So these are machines that are old. Let me tell you, you see the size of this table? When I started at Ohio State in 1983, we had a flow cytometer that went from here to the end of a table, all right? That was a flow cytometer. And you had to come in every morning, open up your toolbox, align the beam, hammer it a little bit, kick it, move it, and then after a couple of hours, you could now fire it up and you could run 2 or 3 samples, and you were going, well, and what does all this mean, okay? Now, the ProCyte has a flow cytometer inside, okay? So now you get a flow cytometer that is about this small, and they work a hell of a lot better than the old ones. So a flow cytometer uses the following principle. I'm going to show you this graphic. You have a laser beam that is pointing constantly, okay? So in this case it's red. In my case, my pointer is green. And as a cell goes through, it interferes with a beam of light, okay? So the time it takes for that cell to go through, the amount of light that makes it through the cell, the amount of light that bounces off the cell will actually give the cell a name, all right? So when these machines go to school, they introduce them to the red cells and the reticulocytes and the platelets, neutrophils, eosinophils, basophils, monocytes, and lymphocytes, all right? So they learn all those cells in school. So what the instrument does is, if the cell is this big and is this complex and so much light bounces off, it's a lymphocyte. If it's this big and this, it's a different cell. Does that make sense, you guys? And I'll show you, if we do one of the cases, I'll show you how we can use flow cytometry to look for organisms. We can actually use it to look for antigens on the surface of red cells and whatnot. And that probably will be something that in the next 5 or 10 years we may be able to do with ProCyte or similar instruments. So bottom line is, the flow cytometers are very, very accurate. And remember, they are particle counters. So as these cells are going up, so remember, all these instruments evaluate the red cells first, then they lyse them, and then they evaluate the white cells. So you do 2 runs. You do a red cell run, and then you do a white cell run. And the platelets are usually done in the red cell run. So in order for these cells to go through one by one, they get swollen a little bit with a hypotonic solution. So remember, a red cell is like a dish, okay? So if it's a dish, you don't know if it's going to go through the laser like this or like this, okay? So it will have totally different optical characteristics. So if you swell them up a little bit, they are all a balloon and they all go in the exact same order. And the machine actually has a little pump that suctions all these cells up, and it counts anywhere between 8,000 and 10,000 cells in one run. And the ProCyte, you guys know, does that in 2 minutes. So you do the red cell run, takes about a minute. You do the white cell run, takes another minute. The impedance counters that are really, really popular because they are inexpensive and they are easier to maintain, instead of using an optical device, they use an electrical field. So you actually have an electrolyte solution, and you have a positive and a negative pole. And as the cells circulate through or in between those 2 poles, they generate an electrical stimulus. And that electrical stimulus determines the size and the complexity of the cell. You get these little graphics that are not dot plots, but they are histograms. As you can see here, those are platelets and red cells. And they are good at counting particles, no question about that. They are pretty good at counting platelets, but they are not very good at sorting cells out. So when you get a 2 or 3 part differential, one of the issues that we have found with this, I was telling the group yesterday morning, I'll give you this case that we saw a few months ago in the clinic. 5-year-old male intact boxer goes to the veterinarian because the dog has difficulty defecating, so he's straining to defecate, has tenesmus, and he's febrile, all right? When the veterinarian examines the dog is walking with a hunched up back and the caudal abdomen hurts. They do a rectal exam and the dog has asymmetrical prostatomegaly with the bigger side being painful, all right? So this dog just came in, shook our hands, and he said, "Doctor, I think I have prostatitis, all right? Please help me out." So they did a CBC with an impedance counter without looking at a blood smear. So this dog had a 70,000 white count, and the dog had 70% lymphocytes, all right, so about 50,000 lymphocytes, and about 20% neutrophils. So they looked at the results, they did not look at a blood smear, and what diseases will give you 50,000 lymphocytes? Are they good or bad? Bad, all right, so leukemias, okay? So they said, this dog has leukemia, send him to the oncologist, all right? So they listened to the dog, they didn't listen to the dog, they listened to the instrument. So the dog comes in and we go, how curious, this dog looks like a prostatitis dog. So we look at his smear, and the 70% were actually neutrophils. So the machine, for whatever reason, said, to me, those look like lymphocytes, so I'm gonna call them lymphocytes. So if you have an impedance counter, you likely have to do manual differentials in all the samples, and that's what we used to do when we had impedance counters in the clinic. To give you some idea, in the oncology service, where we used to see about 80 to 100 patients a week, and we do probably 15 to 30 CBCs a day, depending upon the day, we have not sent samples to the lab for the last 9 years. You know, we did the last 3 years with the ProCyte, the previous years with the LaserCyte. So we run them in the onco service, and they work out really well. So there is a lot of different instruments that do different things, but remember the flow cytometry, the original LaserCyte and the LaserCyte DX are flow cytometers. And when you look at the ProCyte, actually uses impedance and it uses flow impedance and flow cytometry. So they're really, really good machines. The ProCyte that you guys have here, you probably know this, is a mini version of one of the Sysmex machines that costs 120,000 euros or something like that. And it does not only the same that the other machine does, but it does it better because the software, the algorithm is for animals instead of for humans. So it works out very, very well. So we've done probably about 10,000 CBCs with the ProCyte, and so far we have had 0 downtime, and we have had no bad issues with the instrument. The only one that this may be interesting for you with the onco cases, we had 3 cats on chemotherapy where it will not give us a white cell dot plot, and when we would repeat it the next day, we would get a white cell dot plot. And when you look at the blood smear, it looked fairly normal, but that's the only 3 things that I've seen that didn't fit the bill. So you went to vet school, and they told you that if you look at the numbers, if they are high, it means one thing. If they are low, it means a different thing. And you have red cell parameters, and you have white cell parameters, and you have platelet parameters. And you know, in the old days, the students actually used to sit there and put the arrow pointing up or the arrow pointing down, and that was half of the excitement trying to figure out what the dog had. And now the machine spits that out, and it tells you if it's low or high. So if you have a wellness visit, obviously you want for all the values to be in the middle, because if there are some that are low or high, that means time. You know, need to go and talk to mom or dad and explain to them why these values are abnormal. So when I read a CBC, one of the things that I was telling the group last night is, so I have a working diagnosis, all right? So I think this dog has IHA or ITP or babesiosis or whatever. So I look at abnormalities in the values, abnormalities in the dot plots, and abnormalities in the smear, but I also look for changes that are missing if this dog were to have the disease I think he has. So, and let me give you an example. Yesterday, I just all of a sudden thought about this dog. We saw it in the clinic a few months ago. 5-year-old, male castrated terrier, Jack Russell Terrier type dog, little dog. Comes in status epilepticus. So he's been seizuring for about 4 hours. They take him into the emergency room. They do a CBC and a profile. He has a very, very low blood glucose. You know, our units go from 80 to 120 milligrams per del. He has a glucose of 20, almost non-detectable, all right? So we talk to the owners, no history of medication. You know, the dog has been healthy until now, blah, 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 blah. Too young for an insulinoma, but we're thinking this dog has an insulinoma. So they put the dog on a glucose drip, and they cannot correct the glycemia. They just cannot correct the glycemia. So you go back, talk to the owner, who now has calmed down a little bit because the dog is stable. You know, we have given the dog propofol and whatnot, and the dog is doing well. And the owner goes, do you think this could have been that insulin that I gave him this morning? And we go, oh, certainly, it could be that insulin. Well, the owner realized that she was very nervous. She forgot to tell us the dog is a diabetic, and He didn't look good that morning, so she gave him a lot more insulin than usual. So we said, well, that's it, okay? But guess what? We could not correct the glucose, all right? So he remained hypoglycemic, and the clinicians had looked at the CBC, and the CBC was normal, okay? So now let me give you the results of the CBC. The dog was a little hemoconcentrated, had a hematocrit of 51 and a high protein, and he had a neutrophil count of 2.8, okay, and a lymphocyte count of 6.8. All right? So let me ask you this. What will be an appropriate leukocyte response for a dog that has been seizuring? What would you expect to see with the neutrophils? Would you expect for them to be low or high? High, all right? And what would you expect for the limbs to be, low or high? Low, because they should have a stress leukogram, shouldn't they? So why would this dog not have a stress leukogram? What could he have that could affect the glucose regulation? Addison's, all right? So they did an ACTH stim, and he went from 0.1 to 0.1. So he had Addison's. Once we treated the Addison's, then they started regulating the glucose much better. So bottom line is I always look for things that are missing, all right? So why is this not there? You know, I just want to see why it's not there. So you guys print your dot plots, so I don't need to tell you how to print them. In our hospital, what we do, and we do this, a lot of private practices actually do that. So we sit down with the owner when the dog goes home, and we explain what the dot plots are. We do a mini version of what I'm going to do with you in a couple of slides. And we explain to them that each one of them is a cell, and the owners are delighted that the machine that my veterinarian has can see Fluffy's cells, all right? And look at the eosinophils are green, and this are da, da, da. So this is very good PR, because the owners always go and tell other people, your veterinarian doesn't have this machine. You know, you cannot see your dog's cells like my veterinarian can. So, and our owners, cancer owners in the States are very, very dedicated, all right? So our owners usually bring a big folder with all the lab work, all the medical history from the time the dog was born until now. The dog had passed some gas yesterday, so it's recorded in the history. And our owners actually remember the values, and they come over and they go, well, today the neutrophil cloud doesn't look right. And you go, well, because he has less or he has more or whatever. So people get really into it. So we talked about clouds, and you know, you can actually look at them from a different perspective, but you know, they are spots, all right, or clouds or whatever you want to call them. And how many of you guys feel comfortable reading dot plots? First of all, how many of you have read dot plots? Raise your hands. All right. So nobody else have read dot plots? Have you guys seen dot plots? Yes. Yes. All right. So what I'm going to do is I'm going to tell you how easy it is to read dot plots. All right. In the United States, there is a commercial for a car insurance company that says it's so easy that even a caveman can do it. All right. So you can get this big club and dress up as a caveman. So with the laser, you are interrogating each red cell as they go through, all right? And this is actually the size of the red cell population. So if you're near the bottom, you're small. If you're near the top, you're big, all right? Pretty easy, pretty intuitive. The horizontal line looks at fluorescence. So when the laser interrogates the cell, if the cell has RNA, because there is a fluorescent dye, the cell will glow, all right? So when it glows, the more RNA it has, the more to the right it will be. Okay? Make sense? So far, so good? So if you look at a normal dog red cell population, this is what it looks like. It's a long, elongated ellipse, if you may. The cat is a little chubbier. And if you look at the middle of this curve, so let's say that's the middle of that population, that is actually your MCV. So the mean cell volume is the middle of that curve, all right? So depending upon where this cloud sits, if this cloud sits really low, the dog has microcytosis, all right? If the cloud sits really high, the dog has macrocytosis. Very easy. It's very, very visual, you know. And you guys have normal dot plots to compare them to. So the reticulocytes, remember, are bigger than the red blood cells. And remember, they don't have nucleus, but they have RNA, and that's why they're called reticulocytes. So when they are interrogated by the laser, they fluoresce, so they will be towards the right of the red cell population. And if you notice, most of them sit on the upper half of the curve because they're bigger than the red blood cells. So remember, the MCV of a reticulocyte is about 80 femtoliters, something like that, in a dog. And then remember, the platelets are very small, so they will be in the bottom of the horizontal axis, but as they get bigger, or they have new platelets, or they have clumps, they climb up to the upper right-hand corner. And remember, the platelet curve in a cat is very different because it's more dense and you have all these big clumps sitting around. So very, very easy for you to visually, and I'll show you cases and you're going to tell me what it is without ever having looked at a dot plot, all right? Very, very easy. Okay, so when you look at the white cells, so remember, in the red cells, remind me, do they have nucleus in the dog or not? No, all right? Do the reticulocytes have a nucleus? No. And do the platelets have nuclei? No. How about the white cells? Right, so the white cells have nuclei. So what actually happens is, when you interrogate a white cell with a laser, you're not looking for RNA, but you're looking for RNA and DNA, okay? So the DNA is in the nucleus, and the RNA, if you have a toxic change or a reactive lymphocyte, is in the cytoplasm. Make sense? All right. So to make our lives easier, IDEX actually changed the parameters, so the curves actually look very, very similar. So what you have here, remember in red cells, this was size, okay? So the way I think about this is fluorescence to me tells me how big the nucleus is, all right? So how big is the nucleus in relationship to the cytoplasm, okay? So NC ratio, in other words. And when you look at the horizontal axis, that means how much light is dispersed by something inside the cytoplasm, all right? So that means stuff in the cytoplasm, granules, toxic changes, vacuoles, things of that nature, okay? So remember, by convention, the neutrophils are lavender color, and they sit there, very, very pretty. And the eosinophils, remember, have a nucleus that is about the same size than a neutrophil in relationship to the cytoplasm, maybe a little bit bigger. But what do you think? Is the cytoplasm of an eosinophil more complex? Does it have more things than a neutrophil or not? What do you think? Has more things, so it should be to the right, okay? So that's where the eos actually sit in the dog, because when the beam is going through the cytoplasm, it's bouncing off all these red granules, all right? Make sense? So the basophils actually sit right there. You probably will never see a dog with basophilia, I don't think, because it's very unusual, and we don't see it in Ohio because we don't have heartworm disease. So now, the one thing that you need to do, and it's difficult to do, is if you're used to looking at these cells under microscope, you have to erase a little bit of that in your head and remember that the machine is not a microscope. So the machine is not looking at the morphology of the cell, but it's looking at the size and the complexity, all right? And you go, if I put a lymphocyte in there, it's telling me that its nucleus is a lot bigger than the cell, but what it's actually telling you is that the nucleus is a lot bigger in relationship to the volume, because remember, a lymphocyte has a very narrow rim of cytoplasm, okay? So don't think about the neutrophil is bigger than a lymph, and the lymph has to be further down, because this is just complexity and amount of nucleus. And the monocytes, remember, have a big folded nucleus, right, with a lot of proboscis, if you may, and they have a vacuolated cytoplasm. So they are higher up, and they are to the right. Make sense? So this is a normal dot plot in a dog, and I'm going to show you just dog dot plots, at least for now. Okay, and remember, you lysed all the red cells on the first run, but some of the red cells were not completely lysed, so those are pieces of red cells sitting in the bottom of the curve in orange. I didn't show you this. I'm going to go back to this one and show you one thing. If you have a dog, for example, with a hemangiosarcoma or a dog in DIC, you will see a fragment message, because you will see a dense population of cells there in the bottom that will be color-coded dark orange. And when the machine tells you, it gives you the fragment message, go look at this mirror, because you're going to find fragments in this mirror. Works out pretty darn well. Okay, so you've seen this, so I'm eagerly pushing this button so you don't get bored. Okay. What is that? It's an apple, or una manzana, if you would like the Spanish. So if you were to ask somebody to describe that, okay, would you agree with me that they will use probably those two terms? Yes? Okay. So when you're a child, they show you this and they go, this is an apple, and it's red and it's round. They can also be green, but this one is red and it's round, okay? So then the next question that you ask yourself is everything that is round and red an apple? No. Or no. If you want to say it in Spanish, it would be no. All right? And the reason for that is because there's a lot of different shapes and forms and colors in this world, all right? So the apple never patented the shape and the color, okay? So what do you think happened? So when these cells went to school, and they showed them all the pictures, when these machines went to school, and they showed them all the pictures of the cells, they tell them, if this cell is red and is round, it's an apple, all right? But they didn't tell them that they are plums and cherries and balloons and balls of yarn or whatever. So the next time something red and round appears, the machine, what will the machine call it?
Apple.
An apple, all right? And it may look at it and they say, you know, it's an apple, but wait a minute. It looks a different red, or it's a little flatter, or it's a little bulkier, or it's a little redder. So I'm going to put an asterisk next to it, and I'm going to tell the guys there is a distribution issue with the white cells, because I think it's an apple, but it may be something different. Make sense, you guys? All right, so I'm going to show you real life cases here in a minute. Question for you. So we do this trick all the time. How many of you see a nun in this picture? Raise your hands. Okay, so anybody sees a sailor that is standing in front of an arched doorway? Yes? Look at his little hat. He's just standing in front of a door. He looks scared. He's looking at you. All right? So what is it? Is it a nun or is it a sailor? Or is it a nailer or nailer or niler or whatever? Well, this, you guys remember, is called ambiguity. Okay? So what this means is that your eyes will look at something, my eyes will look at the same thing, and we may reach different conclusions. Okay? And correct me if I'm wrong. Has this ever happened to you that you show a radiograph to a radiologist and the radiologist tells you, they will not tell you, I think it's this. A radiologist will tell you, unquestionably is this, all right? And then you show it to radiologist B and he tells you, unquestionably is this other thing, all right? And then you go, well, which one is it, okay? So then you have to go shopping for opinions and things like that, and that's not a good thing for your patient. So the deal is, it's important for you to remember that our eyes can trick us, all right? And when we look at cytology, when we look at ultrasounds, at radiographs, at whatever you name it, we will have to deal with this. So you have to sort of tune a little bit your brain. Now, if I have an anemic patient, I like to use this graphic to actually classify them because it helps me a lot. But it also gets me in trouble with IDEX because IDEX doesn't like this particular approach. And I've had this discussion with Dr. De Nicola, and I'll tell you what their version is. That is good, but it doesn't work for my brain, all right? So if a patient is anemic, the first thing that I want to know is, this is one of the ways you go about anemia, if it is regenerative or not, okay? I'm going to tell you about this one in the middle in 1 minute. If the anemia is regenerative, the books tell you that because the reticulocytes are bigger and because they have less hemoglobin, it should be macrocytic and hypochromic. Let me ask you this. Do you think that textbooks are wrong at times or not? Oftentimes. Because you can say whatever you want in a book because it's not a peer-reviewed publication, all right? So, you know, like we were saying, yes, you can say all the dogs in Ohio are green and have a purple tail, all right? And, you know, you just write it in the book and everybody keeps talking about it. But remember, in actuality, only about less than 20% of the dogs with regenerative anemia have macrocytic hypochromic indices. So if you see macrocytic hypochromic indices, it's good because it helps you sort out, yes, the dog has regenerative anemia, but most of the regenerative anemias will be normocytic normochromic or normocytic hypochromic. So that's why being able to look at reticulocytes is so helpful, okay? So it's called regenerative because, so remember, you need a dog or a cat or a ferret with a healthy bone marrow and 2 healthy kidneys, all right? So they have to be able to make erythropoietin. That erythropoietin has to go to the bone marrow. It has to stimulate red cell production. It takes a few days for the retics to come out of the marrow. And remember, we always say 2 to 3 days. In an older sick dog, it may take 5, 6 days for a dog to retic after they bled or they hemolyze. And remember that the only two things in this planet that can give you regenerative anemia in a dog are blood loss or hemolysis. So what you must do is you must kill or lose red cells, give them enough time for the kidneys to release EPO, and then wait for the reticulocytes to come out. Make sense, you guys? So if you're a clinician, regenerative anemias are a lot easier to diagnose than non-regenerative ones. And in regenerative anemias, the smears help you a ton, okay? In the non-regenerative anemias, the smears may or may not help you. But in the regenerative anemias, because a lot of them are infectious, or you see inclusions, or you see morphologic red cell changes, they really, really help you a lot. So we're going to skip the one in the middle, and I'll tell you why here in a second. Most of the books that you will read tell you that the anemias come in two models, regenerative and non-regenerative, all right? And if you use those two models, then you miss this one that is very easy to diagnose from just looking at the numbers or the dot plots. If you have a non-regenerative anemia, these anemias are boring. I'm not going to lie to you. The smear is, there's really nothing exciting to look at. Their red cell parameters are normal, so they're normocytic, normochromic. The most common form is anemia of chronic disease. So remember, if you have chronic disease, you have release of cytokines and leukotrienes, and you sequester iron in the bone marrow, so you have a lot of iron stored, but you don't make it available for red cell production. So they have a relative iron deficiency, if you may. Chronic kidney disease can do that, bone marrow disease can do that, and endocrine, I have it in parentheses because it's extremely unlikely that you will see a dog or a cat with an endocrinopathy come to you for evaluation of anemia. So they may have a mild anemia, but it's not a big deal. I like this third category here, and I tell you why. Our service at Ohio State is called Oncology and Hematology Service, all right? So we get a lot of heme cases referred in, or second opinion. One of the most common causes of anemia that we get referred in is iron deficiency. So how does this dog come to you? Weight loss and anemia, all right? So if somebody's not familiar with the indices or the dot plots, they will not know what the dog, why the dog has anemia. But if you look at the indices or the dot plots, you will nail it instantly. My expectation, as I was telling the group last night, is that a first-year veterinary student should be able to diagnose iron deficiency. Very, very easy, okay? And what do these dogs usually have? A tumor in the jejunum, all right? It's not in the stomach, it's not in the ileocolic valve down, so the dog has intermittent melena. You cannot palpate the mass because this tumor may be a centimeter in diameter. Quite often you will not see it with the ultrasound. And God places it far enough from the tip of the endoscope that you will never see it, okay? So the way it works is you have a dog with weight loss and iron deficiency anemia, and you don't know what is going on. And if you end up exploring those dogs, you usually find a leiomyosarcoma in the jejunum, or you find, have you guys ever heard about the GISTs, gastrointestinal stromal tumors? So they are leiomyosarcomas with a c-KIT mutation. So they are basically bad, evil leiomyosarcomas, okay? So remember, the typical presentation for a Lyo dog is weight loss and melena with iron deficiency anemia. So how do you pick them out of a lineup? Because the red cells are very small, they don't have enough hemoglobin, there are lots of platelets, okay? My record is 2.5 million platelets in a dog with iron deficiency, so they have lots of platelets. So many that sometimes when you look at the smear, the first thing that catches your eye are the platelets. And because remember the Lyos come from the deepest layer of the intestine. So when they grow into the lumen, they bring blood vessels with them. And when they bleed, I have to tell you, they really bleed. I mean, they sometimes have arterial bleeds, all right? So the dogs can come to you with collapsing episodes because they just bled into the intestine and they just collapse from hypotension. So what happens is, if the dog had a big bleed today, what do you think will happen with the reticulocytes 3 days from today? They will be up, all right? So then when they stop bleeding, the reticulocytes go down. So the retics go up and down, up and down. So you can have, 4 to 10% retics, or, 80,000 to 300,000 retics, give or take. What I'm going to do is I'm going to tell you a few more things about anemia, and then I'm going to show you this graphic with the corresponding dot plots, okay? So stay tuned for that one. So any questions so far? You guys okay? Yes.
The hemophagocytic spleen, histiocytic
Yeah, so if you have, yeah, so if you have a histiocytic sarcoma, so you guys remember the histiocytic sarcomas or malignant histiocytosis, depending upon what school you subscribe to, and I like to call them histiocytosis, is the tumor of the new millennium, all right? So it's a tumor that we basically discovered about 20 years ago. We started looking at it. It's a breed-related tumor. You know, I saw 2 flat-coated retrievers there in the ward, and I said, oh, that's not a good thing because, you know, we have had entire litters of flat-coated retrievers die of histiocytic sarcomas, and Jane Dobson at Cambridge has published extensively. It's the #1 cause of death in the breed. We see it in Rottweilers, we see it in Labradors, we see it in Golden Retrievers, and we see it in some other breeds. But those are, and Bernese Mountain Dogs, of course, are the biggest. In our clinic, most of the ones that have regenerative anemia are the Goldens and the Labs because they are more likely to have the hemophagocytic form of the disease. So there is one variant of the disease where the tumor cells eat red cells and platelets. Sometimes they eat neutrophils, but usually red cells and platelets. So those guys come to you with spherocytic hemolytic anemia with thrombocytopenia, okay? So if it's a Cocker Spaniel, you will call it IHA, all right? You will say it's an immune-mediated hemolytic anemia because the macrophages are eating bites out of the red cells and turning them into spherocytes. They're Coombs negative, of course, but we see them in Labradors and Goldens more often because those are, at least in Ohio, the ones that have the hemophagocytic form more often. If you have a plain histiocytic sarcoma in the spleen, it depends upon what's going on in the spleen. So you guys remember splenomegaly changes the microenvironment of the spleen. So if you have a diffuse enlarged spleen, the pH goes down, the glucose goes down, the P50, the PO2 goes down. So you damage the membrane of the red cells, and a lot of those with generic splenomegaly have hemolysis. And probably the best example, you guys have probably seen isolated splenic torsions. Have you guys ever seen just a splenic torsion? The splenic torsion dog comes to you with massive hemolytic anemia. You know, they have, that's the presenting complaint, abdominal distension and hematuria. It's just hemoglobinuria from massive hemolysis. All right, so why do we need to look at the infamous blood smears? Because basically they are our quality control. So if the instrument tells us something, so you're, let's say, test driving a new instrument, or you just bought this new instrument, you really want to know if it's good or not, don't you? You know, you just want to have some quality control. So the way you can do that is easily looking at all the blood smears in all the samples as you start doing that. These machines, so far, do not give us any information on red cell morphology. You know, yesterday I was commenting on this. So there is an abstract that just came out from France on a case report of a dog that has babesiosis, all right? And they showed the dot plots with the proside, and they put an arrow pointing at red cells that likely have the babesia. So you see a different population. So guess what that turned into with Facebook? The proside can diagnose babesiosis, all right? So now you probably don't even need to put the dog blood in. You just scan the dog with the proside, and it tells you if they have babesiosis, all right? So you have to be really careful. But we're learning a lot about all this, and you guys know, well, you have a new instrument, or you have it for 2 years. So you had the old algorithm that didn't detect left shift or toxic changes. You had the one that didn't detect nucleator reds. You had the one that didn't detect fragments. All those are new algorithms that work very, very well. And I have to tell you that we probably provided more than half of the data that they used to generate the algorithms, because what was the interest of IDEX in our population of patients? They are all messed up, all right? So we don't have normal CBCs, so we have everything weird and wacky. So, all right. So I was debating whether I should talk to you about blood smears because the BMAs do most of that for you, but I figure we were saying if you're in an emergency, maybe you want to look at a blood smear and see what's going on. So in order for you to look at a blood smear and get information, you must make a good blood smear, okay? And I always tell veterinarians in the States, you want to learn how to make a blood smear? Ask your technician, and in your case, your BMA, to teach you how to do it, all right? Because we veterinarians don't know how to make smears in the clinic, all right? So we put a big drop, a little drop, you know, the sender goes in different directions. So And then guess what? You practice and you practice and you practice until all your smears turn out the same, okay? And when you read in the books that the space in between the red cells allows you to determine the hematocrit of the dog, what is your first reaction when you're a veterinary student? Yeah, right, okay? Because your first smear is this thick, the next one is this thin, one is this long, the other one is this short. But if you make them all the same way, you can fairly accurately guesstimate the hematocrit from looking at the space in between the red cells. So you'll put a blood drop down there, and then you smear it in that direction. And remember, most of the blood smear is waste, okay? So all this stuff goes away. And you have the feather edge. That is an area that you look at very rapidly to make sure there are no tumor cells, filarias, weird looking, circulating plasma cells, or the occasional weird macrophage in the blood. But bottom line is, you will actually go to the counting area. That is what we call a monolayer. That is about, if you're under oil immersion, you're about 2 oil immersion fields away from the feather edge. So you will see red cells that sit individually, and half of them are touching the neighboring cells. So the monolayer means half of the cells are touching the one next to them. So the way you have to think about it is, remember, the red cells in the dog have central pallor. So you should be able to see the central pallor really, really well, because that means this cell is sitting really flat, okay? So think about a fried egg, okay? So you can see the yolk and you can see the white, okay? If the cells are looked at or examined or evaluated in the feather edge, remember, those cells dried instantly, right? So you made a smear and they dried instantly. So the red cell is a boiled egg, okay? You cannot really see through it, and I'll show you a slide of what a feather edge looks like in a normal dog, and everybody says spherocytosis, all right? Because you cannot see the central pallor. So then what we do is we go to work, and we usually do, if you guys probably have gone to IDEXX Learning Center, anybody had gone to that website? Very, very good website. A little tricky sometimes to find information, but they're working on making it a little bit more user-friendly. But my advice is, if you like hematology, go to that website and look at this video that is called The 3-Minute Blood Smear by Dennis De Nicola. It's a great video. You download it. It's like a 40-minute video. You can watch it and stop it whenever you want. And very, very good. And like digital radiology, if you spend more than 3 minutes looking at something, you're going to start imagining things, right? So 3 minutes, perfect. You diff quick it. I use diff quick for all my blood smears and all my cytologies. And, to be quite honest, when you're busy on the clinic, I don't even dry the slide, okay? So I dry the bottom so it will not get stuck on the plate of the microscope. And you guys remember, it's the same in Sweden. Oil and water do not mix, all right? So how do you actually fix it? You put a lot of oil, okay? So you just cover it with oil, and you look at the damn thing and you move on to the next case, all right? But don't teach that to the students, because we always tell them, never do that, okay? Never ever look at a wet slide. So at low power, if you use a 10x objective and you have a 10x eyepiece, you will look and see if you have a good smear, where are the cells, where is the counting area, where is the thick area and whatnot, and then see if there is autoagglutination or, rouleau formation or coin stacks, and find your counting area. There's, remember, at least 4 formulas to calculate white cells, so you can use whichever you like. This just happens to be one of them. And then once I've done this, and I do it in an organized fashion, I do that old Greek festoon, up, side, down, side, up, bum, bum, bum. Then I put oil, and remember, as I was saying yesterday, if you were to have a microscope dedicated to do cytology, and you were not doing sediments and skin scrapes and whatever, the first thing you will do is you will take out the 40X, all right? Because remember, the 40X, always somebody comes in at night and puts oil in it. So when you come in the morning, the little gremlin come in and just put a little drop of oil, and now it's dry, you have to clean it and use xylene and whatever. So if you have a microscope that you will use a lot for cytology, a really good investment, and I think you can get one for about 600 euros now or 700 euros, is a 50X oil. So there is a new line for most of the companies. Olympus has it, Nikon has it, Motic has it, I'm sure Zeiss has it. It's a 50X oil. So basically, you want for it to have oil, so you don't need to worry about that person coming in at night and putting oil on your microscope. And it works very, very well. It gives you can use it for sediments, for skin, for whatever else you feel fit. So when you go at high power, I usually leave the best for last. So if I have a dog with anemia, I look at the red cells last. But I guesstimate the platelets. So remember, if you're looking at an oil immersion field, each platelet is about 15 to 20,000 per microliter. So you can get a fairly good semi-quantitative platelet evaluation doing that. And again, this is my gold standard for cats, all right? So I just get a fresh blood sample, and that's my baseline platelet count. So you guys remember, platelets in the cat in EDTA aggregate proportional to time in storage. So if you're sending the sample to a reference lab and it gets there late tonight, their platelet count will be lower than when you did it in the clinic this morning. And then you may attribute that to the analyzer, but it's usually platelet aggregation in the tube. So yesterday I showed this cartoon because I think it's helpful for you to understand a little bit the mechanism of hemolysis. And everybody understands intravascular hemolysis. You guys remember from immunology when we learned about type 1, 2, 3, and 4 hypersensitivity? You guys remember that? So we remember type 3, that you have an Arthur's reaction. Type 2, you activate complement and you bust the cell membrane. So if you have intravascular hemolysis in, let's say, a cocker with IHA that has intravascular hemolysis, that's because they have either IgM, that is not common, or a lot of IgG, that is the most common presentation. So if you have a lot of IgG around the cell, you activate complement, that makes a hole in the membrane, and the cell explodes, all right? So the hemoglobin, of course, is red, and if the cell explodes, what color will the plasma be? Pink or red, all right? So when you centrifuge that hematocrit, your plasma would be red or pink, and that is strict intravascular hemolysis. You will see that with DIC patients, you will see that in hemangiosarcoma, you will see that in the big Babesia canis, for example. You will see that in the northern Spanish Babesia, the Theileria annei. But intravascular hemolysis is lot less common than extravascular hemolysis in the dog. So the extravascular hemolysis is the one that kind of always bothered me because I couldn't quite explain it well to the students. So the way this works is as follows. This is a macrophage, and let's say this is the spleen, okay? So you guys remember the spleen is a sinusoidal organ. So what does that mean? That the capillaries have holes in them, okay? So the spleen is actually sitting here, looking through this hole into the capillary, okay? Like this guy sitting there. And is looking, waiting for a red cell to come through, and that red cell has to have some little label that says, I'm not good, you have to eat me, or something like that, okay? So that label could be, antibodies on the surface of the red cell, could be Heinz bodies, could be inclusions, could be a thickened cell membrane. There's lots of different things that make the macrophages hungry. I remember all the macrophages have these FCRs. Remember the FC receptors? The long arm of the immunoglobulin G is called FC portion. And you guys remember when the antibody binds to the antigen, the FC portion changes conformation three-dimensionally, so now it's recognized by the receptor in the macrophage. So this macrophage sticks a paw through this hole, grabs this red cell, tries to take it out and eat it, okay? Now what is the problem? The problem is that the red cell measures 7 microns, and the hole measures 2 microns, okay? So what do you think, likely or unlikely that it will be able to take this whole red cell out and eat it? Unlikely, all right? Because he has to have a big mouth like this, and it's not, that ain't gonna happen, all right? So then here's what happens. You have lots of macrophages everywhere. So think about them as a band of angry chihuahuas, all right? So here's what actually happens. As these red cells are going through, the macrophage goes, I cannot eat this son of a gun, so I'm just gonna bite it, okay? So as the red cells go through, they go, and as they go through the spleen and the marrow and any other sinusoidal organ, the macrophages are taking pieces of membrane and cytoplasm, okay? So you guys remember a red cell is a biconcave disc, correct? And why is it a biconcave disc? Why does it have so much membrane? What must it do? What shape does it turn into a capillary? What is the diameter of a capillary? 2 microns, all right, or 3 microns, and a red cell is 7. How do you make a red cell go through a capillary? Help me out. You squeeze it and you turn it into a sausage, all right? So why do you turn it into a sausage? Because now the hemoglobin is really close to the wall of the capillary, and you can exchange oxygen, all right? So what do you think will happen if the red cell were, instead of being a flat disc that has a lot of membrane, if it were a sphere full of hemoglobin? What will happen when you try to squeeze it and make it go through a capillary? It will explode, all right? So the red cell is a biconcave disc because it has too much membrane, okay? And it has to have that redundant membrane to be able to turn into a sausage in a capillary, okay? So when you lose that redundant membrane, you have a spherocyte. So whether it was a malignant histiocyte that's been taking bites, or it was the immune system in the spleen or the liver or the bone marrow, is all the same. You know, a spherocyte is what is left over after the macrophages have been feasting on these cells and eating little pieces, parts. Make sense? All right. So I'm not going to bore you with that. So this is a spherocyte, and so I'll show you this mirror, and I ask you this. Do you think, so this is, I'm not going to give you the signal, man. You're going to tell me what it is, and then I'll tell you if you were right or not. What do you think? You want to play that game? Come on. All right. So first, let me ask you this. Do you see a homogeneous red cell population, or there is anisocytosis? Do they all look the same, or they're different? Anisocytosis, right? So remember, that means that when you look at the CBC and you look at the RDW will be high, okay? So RDW is anisocytosis. Okay. Even before we go to the red cells, tell me how many platelets do you see in this field? Two, all right? Is that good or bad? Bad, all right? So remember, this is not necessarily an oil immersion field. It's a portion of an oil immersion field, but maybe there are 4 in that oil immersion field. So is this dog thrombocytopenic if there were no platelets in the feather edge? Yes, all right? So she has anisocytosis, okay? So when I have a dog with anisocytosis, the first thing I like to do is find me something that kind of looks like a normal red cell. So that is probably a good candidate, maybe that one, you know. So about 1/3 of the circumference is pallor, all right? And the rest is normal orange red cell color. So what I do is I look at all the other guys and I go, are they bigger, smaller? Do they have the same color? Do they not? Do they have central pallor? Do they not? Okay? So question for you. This one, this one, this one, this one, and these two. Are they bigger or smaller than a red cell? Bigger, okay? And what do you think, particularly if you look at this one, is the color the normal color of a red cell, or do you see a bluish hue to the cytoplasm? Bluish, all right? So those are polychromatophilic red cells, okay? So if you were to do a procyte CBC, those will be in the reticulocyte cloud. They are blue because they have rough endoplasmic reticulum, and that is RNA, okay? So this will be retex if you were to do a supravital stain, okay? Make sense? So then if this is representative, and I were to ask you, is the anemia regenerative or not, what would you say? Yes, you would say it's regenerative. So you said it's regenerative, and the dog has anisocytosis, and it has thrombocytopenia. So we said if it's regenerative, the dog either bled or hemolyzed. So your brain is going into one of these two directions, and I haven't shown you the plasma, so you don't know what color the plasma is. But you may be saying, well, maybe the dog is thrombocytopenic, and she bled, and this is a regenerative response to the bleeding from thrombocytopenia. There will be one possible interpretation. But then you look at these guys and you go, who are those muchachos? Those are boys, by the way. What do you think? Do they have central pallor or not? So what would you like to call them? Spherocytes, all right? So then give me another interpretation. What does she have? It's a 6-year-old female spayed Cocker Spaniel by the name of Lady, or Buffy, could be Buffy, but it's Lady. So what does she have? Don't be shy. IHA, all right? So that's what the dog has. What else could she have? Nothing, all right? She has to have IHA. So, okay. So this, yesterday I was joking, but there's young veterinarians. Some of you are interns or have been interns, and we have an outbreak of immune-mediated hemolytic anemia in the clinic that starts exactly on June 15th, okay? And people go, is it a virus? Is it a parasite? No. We have the new interns on June 15th, and you're on your first night on emergency, and you really want to diagnose your first case of IHA, all right? And in the process of doing that, you get so excited that you forget that you must never look at a blood smear for cell morphology in the feathered edge, okay? All these spherocytes that you see there is a normal feather edge, okay? They don't have central pallor. Why? Because when you made the smear, they dried right away, so they didn't have a chance to spread out and show you the central pallor. Make sense? So don't do that at home, okay? This is a really cool picture. So this is a scanning EM picture of a blood vessel of a rabbit in DIC. So this is an experimental model of DIC, and it's not Photoshop. This is actually from the 1970s. This photo is historical, all right? Yes, there were cameras in those days. So this is a fibrin strand, okay? So you guys see how this red cell is trying to go through the fibrin strand, and the fibrin is going to cut it, kind of like a piano wire, all right? And here you have Tim Voigt, that is one of the artists at OSU, depicting what happens in a dog in DIC. So as these red cells squeeze through that fibrin, or this could be an abnormal endothelium, as in a hemangiosarcoma, they just get busted, all right? And they get broken into pieces, and those are fragments or schistocytes, okay? Let me show you this. So you're going to tell me what this dog has. So this is an 8-year-old golden retriever by the name of Rusty. In Ohio, by law, every male golden retriever must be named Rusty. So every dog is called Rusty. Comes to us with 2 previous episodes of acute collapse. So the owners get home, they're playing with the dog collapses. His heart is really beating out of his chest, as the owners tell us, and by the time they are calming down and they want to take him to the vet, the dog is doing better, so they don't take him to the vet. Now he collapsed again this morning, and now he's not getting up, okay? So with that history, what is Rusty telling you? I think I have a hemangiosarcoma, right? And I bled in the abdomen twice, I auto-transfuse, and now I'm bleeding too much, and I cannot stop, and I cannot auto-transfuse, all right? So you listen to Rusty, because Rusty always tells the truth, we know that, and you say, well, if you have a hemangiosarcoma, probabilistically, we can confirm that from looking at a blood smear. So remember, 80% of the hemangios have morphologic red cell changes and thrombocytopenia, at least in Ohio, all right? So first, let me ask you this. How many platelets do you see in this field? Nada, all right? Not a single platelet, all right? So then, if I show you this, what do you think? Is that a schistocyte? Yeah. How about these guys? Like, I'll show you those 2 that are better. So they will be like if you take a surgical glove and you fill it up with water, and they have this projection sticking out. Starts with A. AC. Acanthocytes. There you go. Good. And if you look, this is not strategically placed, but you see that little guy down there in the bottom? That's a keratoacanthocyte. So that's a fragment of an acanthocyte. You live in an area like I live. You don't have poisonous snakes in Sweden, all right? So if you don't have poisonous snakes, the only clinical situation where you will see thrombocytopenia, acanthocytes, and schistocytes is hemangiosarcoma. Not DIC, all right? In DIC, you don't see acanthocytes. If you have DIC from hemangio, you will see acanthocytes. So seeing this is as good as doing an ultrasound of the abdomen in the dog, all right? So the CBC, am I starting to convince you that the CBC is good for you? Yes or not? Don't make me work any harder, all right? Okay, so if I were to ask you, so this dog has fragments in there, right? What do you think about the platelets here? Does she have platelets or not? Yes. Lots of platelets, okay? She actually has more platelets than you would expect to see. So if I were to ask you if this is an acute or a chronic DIC, what would you tell me? What would you think? Would an acute DIC allow you to compensate marrow-wise? No, so this is a chronic DIC. This is a septic dog. This dog has a septic focus and has chronic DIC. So this is very typical in the cat, and I'll show you this cat slide. So this is a historical slide. I was telling people, now the way we train veterinarians in the United States is the same way we train students at school in the United States. They are always right. They can never be wrong, okay? And if they are wrong, they just kill the patient. You have to go hug them, praise them, tell them that it's okay. Perhaps they should kill 2 or 3 additional dogs before they have to think about the fact that they did something wrong. And then at the end, you give them a kiss and you tell them, we love you, all right? So that's the way we train veterinarians in the United States right now. So we train them to be responsible. But let me tell you this. Correct me if I'm wrong. you guys, there's a lot of young guys in the room, did you learn more from the things you did right or from the things you did wrong? The screw-ups, all right? So that's what you learn the most, when you mess it up big time. So we wrote a paper in 1992 talking about coagulopathies in cats, and we said that it was amazing that cats with DIC did not have fragments. And that got published, went through the peer review process that goes to show you how well this works, and was a very nice hit of a paper. So then, that bothered me forever. And I had that box of slides in my office, and I would go back and look at them every now and then. And then one day, this little light goes off, and I go, what is that? So we call that a demodectocyte, because it looks like a demodex, all right? So it's a newly, that is not in, you will not find it in Google, all right? So don't go looking for that in Google. So what we found is that most of the cats in DIC had this morphologic red cell change. So I think that is probably a keratoacanthocyte or or a schistocyte in a cat. So bottom line is, look for those little dudes, and we see it in cats with aortic thromboembolism, cats with hypertrophic cardiomyopathy, and cats with cancer. That are the three big DIC things. Okay, so let me show you this. 6-year-old, indoor-outdoor, female spayed cat from Ohio. Comes to us for lethargy, not doing well, she's depressed. On physical, she has pale mucous membranes, diffuse splenomegaly, okay? Lots of space in between the red cells, so you know this cat is really anemic. Question for you. If this field is representative, is the anemia regenerative or not? Yes, all right? Lots of big blue guys, all right? So likely regenerative anemia. Do you see any passengers on the red blood cells? Anybody traveling without paying a ticket, all right? So you have these chains, okay, and then can you guys see those round structures, the ring form? I don't know if you guys can see them. Those little things are rings, and those are the two typical forms described in the literature. By the way, you never see these things. Remember, when we show you a photo of this, it's because it's so beautiful that we're never going to see it again. So usually you see like one little dot or another little dot, and when you go to school, you think every photo you see in the book is the way they will appear in real life. No, that's too good. So we show it to you, okay? So what are those things? Hemobard or mycoplasma, right? So either one of the two. And remember, there's 3 species of mycoplasma. There is Haemophilus, Haemominutum, and Turicensis, right? Those are the 2 big ones. And in Ohio, we believe that the only one that is pathogenic is the Haemophilus. We think that the Turicensis and the Haemominutum are not. We see them primarily in healthy cats, asymptomatic cats. Can you see passengers on those red cells? Right, okay. So remember, we do, I work in a shelter in Spain, and I go several times a year with our students and students from Spanish veterinary school, and we take care of a lot of dogs, and most of the dogs get adopted, so we place 800 to 1,000 dogs per year. And to give an idea of those, about 5% stay in Spain. The rest we send to you and to the Netherlands and to Belgium and to all over the world. And every now and then we send some, even though we test them for infectious diseases, every now and then you will pick up an infectious disease. This is Babesia canis from a dog. And this is, so do you guys have pit bull dogs in Sweden? Yeah. And so you probably see this. Anywhere there are pit bulls, you're going to see this. So let me give you the typical story. So this is actually a 3-year-old male castrated pit bull by the name of Harley. And Harley is a sweet dog, really, really nice dog. He goes to the veterinarian about 3 weeks ago after being hit by a car. So he has a splenic rupture, and they splenectomize him, and he does great. So he's doing very, very well. And now he comes to us with a 2-week history of severe, regenerative, spherocytic, Coombs-positive hemolytic anemia. So he has spherocytes, he has a positive Coombs test, he has mild thrombocytopenia. So the veterinarian has been treating him with prednisone and azathioprine, and he continues to do poorly. So he's doing bad, okay? So they referred him to us because he has refractory IHA and ITP. So he walks in the door, we already know what he has because we see this at least a couple of times a month in the clinic. So this is not peripheral blood, okay? You will not see this organism in peripheral blood in Ohio, okay? You will not see it with Giemsa or Wright's or Wright Giemsa or May Grunwald. You see it with Diffquick. So this is a clinician's bug, all right? They want for us to see it. They don't want for the pathologist to see it. This, you guys, is capillary blood. So what I do is I get blood from the tip of the pinna. So I shave the pinna and I make a little incision with a scalpel or a big needle, and then I take a drop with a hematocrit tube. I just use it as a pipette, and then I make a smear, boop, and then I stain it with Diffquick. And can you guys see all these organisms? So that is Babesia gibsoni, and Babesia gibsoni is a pit bull disease. So it's transmitted through pit bull bites, okay? So if you look at all the cases reported in the US, they were all either pit bull bites. To give an idea, 80% of fighting pit bulls carry this organism in the States. And also in Asia and in Australia, there's a lot of papers from all over the place. And the other cases reported were dogs who were in a fight with a pit bull, dogs who were transfused with pit bull blood, and one dog who was transfused with blood from a dog who had been in a fight with a pit bull, all right? So there are no pit bull related things in the literature in the States. So what is the typical scenario? You splenectomize them, and remember the spleen clears up those cells, and now all of a sudden, boom, you have an explosion of bugs. You know, day before yesterday, my daughter, who's doing an internship at NC State, texts me and she goes, "Dad, I have a 3-year-old pit bull that was splenectomized and has hemolytic anemia." And I go, "Well, get blood out of her ear." And within 5 minutes, she goes, "Yep, she has Babesia." All right. So let me tell you why. Okay, in the United States, for a long, long time, we used to say, "Man, these pit bulls have really bad IHA. We cannot treat them with anything." Well, they don't have IHA. They have secondary IHA because they have an infectious disease. Have you guys seen babesiosis here at all? So it'll be here because I'm sure. I was telling a story. One of my residents who is from Spain. If you're talking to him about a case, he will ask you, "Have you ever seen a pit bull with Babesia gibsoni?" And you will say no, and Pachi will say, "But I'm sure the pit bull has seen you." Okay, so remember, if you don't go testing for these things, you ain't gonna find them. Okay. So the deal with this is that it's a very strange Babesia. It does not respond to treatment for Babesia, all right? I would probably guess that none of you have ever heard about this drug. Anybody heard about Atovaquone? So Atovaquone is actually an anti-malarial drug that they use in humans to treat malaria, and so is artemisinin. Artemisinin is an anti-malarial drug. And we combine that with azithromycin, and we usually do 10 to 15 days course of that. And it works very well. In the United States, this is incredibly expensive, you guys. For a 30-kilo pit bull, this is 500 euros for 10 days. And most pit bull owners are really interested in spending money on their dogs. So the deal is very easy to diagnose, extremely easy to diagnose. So all you need to do is look in the right place. In none of these dogs, you will find it in peripheral blood, extremely unlikely. Why do we see them in capillary blood? Because these things make the red cells stiff and they get stuck in the capillaries, so they get jammed in the capillaries. So if you just go, there's a traffic jam, like rush hour traffic going through the capillaries.
Question?
Yes.
If you treat it, can you cure it?
Good question. I can repeat it. Yeah.
If you treat it, can you cure it, and also can it be reinfected if it has another fight with it?
Yep. Yeah. Good question. So, to be honest, my experience, I probably have treated 15 or 20 of these guys, so I'm not a world expert. The world expert is Adam Birkenauer at NC State. And all the dogs that I have treated, they cleared clinical infection, all right? So what does that mean? That I don't see circulating organisms and that most of them go PCR negative, okay? So you can do PCR for Gibsoni and diagnose them in peripheral blood fairly easily, but blood smear is a lot faster and cheaper. I have never heard about a dog getting reinfected, and my guess is, so remember, these organisms like to hide in the spleen. So if you have lots of pit bulls come to us with active Gibsoni hemolysis, and they have their spleen, all right? So the splenectomized dogs are textbook because they just come to you that way. But remember, these organisms hide in the spleen. So if these dogs now get hit by a car, or they go into a fight and they get badly injured and they are really stressed out, or they have a secondary bacterial infection, then these bugs usually come out of hiding and they can get you in trouble again. But I to be honest, I don't know enough about molecular biology of these bugs to know if anybody has documented reinfection. There are dogs that relapsed after being treated, but I've never seen one. So all the ones that we treated, if you treat them long enough, they do well. What is the problem? So Harley, so what do you think? Harley is on prednisone and azathioprine. Should I keep him on that or should I take him off? So we took him off. So we tapered him off gradually because, the thinking is if you keep him on immunosuppressed drugs, he already doesn't have the spleen, so you're going to make his life a lot more difficult in terms of clearing the organism. Make sense? All right. So 6-year-old cat comes in as an emergency, swollen head, not feeling very well. His mucous membranes are a little dark red, brown. And we asked the owner, what's going on? I don't know. He wasn't feeling very well. Did you give him any medication? No. And then we go, did you give him any acetaminophen? And they go, yes, but only a quarter. Okay? So this, remember, are what we call those bodies. Heinz bodies, all right? So remember, that's oxidized hemoglobin. And this is a cat that took acetaminophen. This, you can see a new methylene blue stain. Those are reticulocytes, and those are Heinz bodies. And this is a cat that had IV new methylene blue before a parathyroidectomy, before a thyroidectomy so that we can see the parathyroids. And you guys know that for example, gastrinomas or insulinomas, we can inject IV new methylene blue and those tumors really light up lovely. So we did the same in the cat, and the parathyroids are very easy to see, but they all get hemolytic anemia from Heinz bodies. So don't do that at home, all right? Don't give them new methylene blue. Okay, so I'm going to show you 2 dot plots, okay? So there's a few of you who don't really have a lot of experience looking at dot plots. And I'm going to show you 2 dogs. Fifi is a 2-year-old Maltese, and Exley is an 18-month-old Doberman, all right? I'm not going to give you the histories for now. I'm going to show you these 2 dot plots, okay? And I'm going to ask you if you can identify one that is regenerative. Does one have a lot of purple dots? Yes, all right? There you go. That will be Fifi, okay? She has so many retics that notice that they are kind of blending in with the platelets. So now remember, some of these may be retics, some of those may be platelets. So the instrument is going to be full because they're very similar. Does Exley have regenerative anemia? No. Now, did you just do any mental calculations? Did you look at reticulocyte numbers to determine if it's regenerative? No. Did you look at reticulocyte percentage? Did you do reticulocyte index? Corrected reticulocyte index? Did you use an iPhone app? You did not, all right? And you all told me that's a regenerative anemia, right? And that's the beauty of dot plots when you're looking at red cell pathology. So Fifi actually is a 2-year-old Maltese that likes to eat things, all right? And she comes to us with diarrhea, abdominal pain, and intravascular hemolysis that also has Heinz bodies in the red cells. And intravascular hemolysis and Heinz bodies in Ohio means the dog has zinc somewhere in her system. And in the States, there is a lot of zinc, throat pills, baby diaper rash, the Monopoly game pieces, the screws and bolts in the pet carriers, the coins, screws, bolts for use outdoors and whatever. So we took a radiograph, and she had a metallic foreign body that we took out. We measured zinc. It was through the roof. And she actually did very, very well. Exley is an 18-month-old Doberman with congenital bilateral renal hypoplasia. So he has congenital renal disease. And Fifi has a PCV of 19, Exley of 20, but you can see how easy it is to distinguish the regenerative response from not. Okay. So I showed you this graph before, and I told I was going to show you the corresponding dot plot. So this is your typical regenerative anemia, all right? And this is your typical non-regenerative anemia. This is Geo. Geo is a 8 or 9 week old greyhound pup from the racetrack, heavily infested with ancylostoma. So he has lots of hookworms. So if I show you this red cell dot plot, so remember I started by telling you that Dr. De Nicola does not like this classification, all right? So the way Dennis looks at this is as follows. I'm going to go back and show you this one and then this one. Dennis will ask you to look at the dot plots and say if they are regenerative or not, okay? So we already said this is regenerative, this is not, okay? So I'm going to show you this dot plot, and I ask you, would you say that that is regenerative or not? Lots of retics? Yes, so you will say that's regenerative, right? So that's another way you can look at it. So then Dennis tells you if it is regenerative, now look and see if the red cells are small. Okay? So what do you think? Where does this curve sit? Lower, doesn't it? So you have two bellies here. You have this one and this one. And remember, what I did not tell you is that before sending him to us, this guy got transfused. So those are probably the donor red cells, okay? So when you look at how low in the curve this sits, you realize that this is going to be a microcytic anemia. Greyhounds do not have a lot of platelets, so these are too many platelets for a greyhound, okay? So you have regenerative anemia with microcytosis and lots of platelets. The only thing that can be is iron deficiency anemia. So remember, for you to get iron deficient, you have to bleed at least 6 weeks, all right, on and off for at least 6 weeks. Make sense? Yes? Did I convince you or not? All right. Okay, so we were driving in the car and we were talking about, so now we have these instruments and we're putting them to good use, and we're finding that as many as 10% of dogs with normal hematocrit have more reticulocytes than they should have, okay? So Andy is one of our blood donor greyhounds. So at Ohio State, we have a very large blood donor program. We have about 200 blood donor dogs and cats. They're all pets. They live at home with their families, and they come and donate blood every not every 6 weeks, 6 times a year on the average. And then we make blood products with that. We make them available to any veterinarian in the States. And to give you an idea, we make about 1,800 units of blood products a year. So we sell them at cost to veterinarians, and all these greyhounds are rescued from the racetrack. You know, I happen to like greyhounds. Greyhounds are not really dogs. They're very different from other dogs, and we learned a lot about greyhounds. And what we do is we get all the severely injured greyhounds from the racetrack, we fix their legs, we pay for it, and then we tell the students, we actually suggest to the students that having a greyhound may increase their grade or their GPA. You cannot tell them, because then you go to jail and they fire you. So we tell them, well, you know, if you had a greyhound, and we pay all the expenses while the dogs are in the blood donor program. So the kids get a free dog for 4 years. So it works out really well. And when they're first years veterinary students, they believe anything you tell them. So it works out very, very well. Okay, so Andy is a very nervous greyhound that is coming in for the first visit to donate blood, okay? I will tell you that a normal greyhound has anywhere between 10 and 40,000 reticulocytes. So if I show you this, so he comes in at 9:25 in the morning, his pupils are like this, he's shivering, he's looking around and going, I don't like this very much. So he's a bit nervous, okay? So he has a hematocrit of 65.8, and he has 79,000 retics, okay? So we let him sit. And remember, we're now saying that under 100,000 is normal. That depends on the breed. You know, we have hundreds of data on greyhounds, and greyhounds run under 40,000 retics usually. So he has more retics than he should, and he has a really high hematocrit. So remember, in the blood bank, we will not collect blood from a blood donor greyhound if the hematocrit is below 50. So 50 and below for a greyhound is anemia, all right? So a normal greyhound runs 50 to 65. So this is still kind of normal, okay? So what we did with Andy is we let him sit with a bunch of greyhounds and relax, and we went back 3 hours later and we repeated the lab work. So we have seen this numerous times, all right? This is one where I have just the handy graphics to show you. So what two things happened there? What two things went down? Did the hematocrit go down? All right, and how about the retics? Okay, so interpret this for me. So one of them is you go, this damn instrument, it's worthless. I just did it 3 hours ago, and now it's totally different. Trust me, when we do the same dog, we've done the same dog every 2 hours, and they look the same. So give me some explanation. So he was really freaked out. He was really, really nervous when he first came in. So that means what hormone is being released? Catecholamines, all right? And cortisol. But catecholamines are the peracute ones. And how can we explain? So it's easy to explain the increase in the hematocrit, isn't it? So what would the catecholamines do? What will they squeeze? The spleen, all right? And then you will go, well, the increase in the hematocrit is somehow proportional to the increase in the reticulocytes. So maybe the reticulocytes are also coming out of the spleen. Now the books tell you that the reticulocytes in the dog can, so remember the cat has a different anatomy in the spleen. The cat is non-sinusoidal, but in the dog, the books tell you that you cannot rapidly mobilize reticulocytes from the spleen because of the anatomy of the red pulp. You don't have open gates for you to shoot those retics into the blood, all right? But as we said before, the books are oftentimes wrong. So here's what we did. Do you guys know if a greyhound has a big spleen? Let me show you an abdominal radiograph of a normal greyhound. Does he have a big spleen?
Yes.
All right. So how about this? So this is the right kidney and this is the tail of the spleen. Not the left kidney, that's the right kidney. Is that a big spleen? Yes. How about this one? Is that a big spleen? It's not a shark. All right. All right. So greyhounds have a huge spleen. All right. So if you look at other mammals, the only mammals that have a spleen like that are the seals and sea lions and all the diving mammals. Okay. So why do you think that a greyhound needs a big spleen for? What do they do for a living? What does a typical greyhound do for a living? They run, all right? I remember the greyhounds in the US actually run basically 500 meters. You know, they do a 500-meter lap. So they take off the gate, they go around, they do the whole lap anaerobically. So they breathe out of the gate, they go 500 meters, and they breathe on the straightaway finish line. So why would a spleen of that size be good for an athlete? Wouldn't you think that it should be smaller so it weighs less? You would say, you know, if you have a race car, you get rid of all the extra stuff that weighs, all right? So how could a spleen be good for an athlete? How about a racehorse? What do they store in the spleen? Red cells, all right? So you would say, this is great because God gave him a big spleen so that they can squeeze all these red cells into the blood, increase oxygen delivery to the tissues, and that's why they do as well as they do. Make sense? So here's what we did. We set up a little lab in the racetrack, and you know, we had a pro site, and we did one day, we went really early in the morning, and we bled 126 dogs that we ran on the pro site in one day. So we put the first sample 9:34 a.m. and the last sample 2:32 a.m. Okay, so we ran 126 samples in a day. We made smears and all of them. We look at all the smears, and we did profiles, blood gases, cardiac biomarkers, thyroid, you name it. You know, we did everything we could do. We were doing a prospective study on exercise physiology in the racetrack. So what we did is we went the next day, and we took 50 of those 126 dogs, and we bled them immediately after the race and 1 hour, actually between 1 hour and 2, because logistically we couldn't do all the dogs in 1 hour after a race, okay? So this is right after a race. So when a greyhound finishes a race, their gums are white, okay? I'll show you the heart rate, but a resting heart rate in a greyhound is 60 to 80. They finish with a heart rate of anywhere between 220 and 240, okay? They finish with a temperature of 40.5 to 42, all right? And I'm going to show you some other data. So when you get blood, this is a 19-gauge vacutainer butterfly, and the blood does not go well through the butterfly. So what do you think? Will their hematocrit increase after a race? So they finish a race with a hematocrit of almost 80, okay? 80%. Think about viscosity, okay? So this is actually motor oil, okay? So that's why greyhounds have a huge left heart. You know, the greyhounds have a monster-sized left ventricle. So you always hear murmurs in the greyhounds. They have a very high vertebral heart score. They have stiff ventricles with the echocardiogram. They have high pro-BNP. They have high troponin I, and they look like heart disease patients, all right? So there's 15,000 greyhounds in the States taking enalapril and furosemide because they're normal greyhounds, all right? So as I was telling you, they are not dogs, totally different. Okay, so what do you think happened to the reticulocytes? Do you think they went up or not? They sure did, all right? So they went up proportional to the hematocrit. So I'm going to go back 2 slides, and I'm going to show you this. I lied, there were not 2 slides, there were like 5. But so when you look, so remember I told you this is fluorescence and this is size. So the young reticulocytes are big and they have a lot of RNA. So the young reticulocytes will be on their upper right-hand quadrant, okay? So when we see this happening, we looked at all the dot plots, and all the reticulocyte clouds are close to the red cell population, which likely means that they are not coming out of the bone marrow, but rather coming out of the spleen or some other organ. So we're now designing a prospective study. You guys know there is not a good way to measure splenic volume in the dog. We now have a new technology, well, not new technology, a new method with ultrasound where we are fairly certain we can measure it. So, okay. How many of you guys like acid base or blood gases? Anybody likes acid base? Good, I don't either. But so I was going to show you something before I move on to that acid base. I'll tell you about this, and then we can do a break. So when do we see dogs that have a normal to slightly increased hematocrit and inappropriately high numbers of reticulocytes? The first one are in clinical practice, when you're the primary care clinician, a dog with hemolysis or blood loss. So you guys remember, during the first 4 or 5 days of hemolysis or bleeding, the marrow increases red cell production as much as tenfold. So it really tries to keep that red cell count going, squeezes the spleen. So you may get a dog, we will not get it in a tertiary referral facility, but in a primary care center, you will get that dog. We were talking about a dog with Dr. Metzger, healthy, normal, 8-year-old Australian Shepherd type dog, not feeling well this morning. Mom, really dedicated owner, and she goes, he's never not eaten breakfast, so you have to do a CBC, a profile, da 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 da. So they do a CBC, and he has lots of reticulocytes, like 200,000 reticulocytes, with a hematocrit of 37, normal hematocrit. He has a fragment message, and he has mild decrease in the platelets. Make a long story short, he had a big hemangiosarcoma in the abdomen, all right? And it was the first presentation, normal hematocrit, lots of reticulocyte. The second one is if you have splenectomized dogs, they almost always, remember, the retics spend 2 or 3 days in the spleen. So if you take the spleen out, they have to stay in the blood, so you have more retics. And the third one, that is the most common one that you will see all the time, if you have a scared dog, a little dog that is trying to bite you, a dog that doesn't like being restrained, you will see lots of reticulocytes. We've seen 300,000 reticulocytes with normal hematocrit. And then I tell you what, you give that dog butorphanol and acepromazine, or any of the other sedatives that you use, and you bleed them an hour later, and the retic counts are normal. So we know that they go up with fright, and they go down when you relax them. All right. So you guys want to do a break? How many of you want to do a break? Good. We have a break then. So then, what I was going to do, let me tell you. I was going to show you 3 slides on acid base, just to show you what a greyhound does for a living. And then I'm going to show you white cell dot plots. And then we're going to do whatever you want. So if you have a case? Perhaps. Okay. Oh, you probably diagnosed it already. That's what happened. He looked at the dot plots and he diagnosed it. Yeah, but if you have a case, we can look at it. If not, I'll show you some more cases. You can pick dogs, you can pick cats, you can do cytology, we can do blood, we can do cancer, whatever you want. So it's all included in the admission ticket. So, all right, break time.